Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 372 of our pharmacotherapy series, which majors in fluid and electrolyte disorders. The first case reads, LAB, a 25-year-old woman with type 1 diabetes mellitus and hypertension, returns to the clinic for follow-up. Her BP is 170 systolic 90 diastolic with a pulse of 80 beats per minute, and her physical examination is remarkable for 2+ pedal edema. Laboratory tests show the following: plasma sodium levels of 135 milliequivalents per liter. Potassium levels of 5.8 milliequivalents per liter. Chloride levels of 108 milliequivalents per liter. Total bicarbonate 20 milliequivalents per liter. A BUN of 28 mg per deciliter. Creatinine of 2 mg per deciliter. Glucose levels of 200 mg per deciliter. Her current medications include oral captopril 25 mg 3 times daily, hydrochlorothiazide 25 mg co-formulated with triamterene 37.5 mg 1 capsule daily, human isophane insulin 30 units subcutaneously every morning, and ibuprofen 200 mg as needed for menstrual cramps. She uses a salt substitute occasionally. So my question to you reads, what is the etiology of her hyperkalemia? Before conducting any extensive evaluation to identify the etiology of hyperkalemia, the serum potassium concentration ought to be repeated to confirm the presence of hyperkalemia. Also to be ruled out are the different causes of spurious hyperkalemia, which can result from severe leukocytosis, that is greater than 500,000 per microliter, thrombocytosis, that is greater than 750,000 per microliter, or hemolysis within the blood collection tube. Pseudohyperkalemia is a test tube phenomenon that occurs when potassium is released from leukocytes, platelets, or erythrocytes during blood coagulation. These disorders can be confirmed easily by comparing serum that is clotted and plasma that is unclotted potassium concentrations from the same blood sample. The two values should agree within 0.2 to 0.3 milliequivalents per liter. Improper tourniquet technique, causing strangulation of the patient's arm before blood sampling, may also result in spurious hyperkalemia. Identifying the etiology of hyperkalemia can be approached systematically by considering possible disturbances in internal and external potassium balance. The former involves transcellular flux of potassium from the intracellular to the extracellular space, whereas the latter involves either increased intake, including increased endogenous potassium load, e.g., rhabdomyolysis, tumor lysis syndrome, or decreased elimination. A thorough medication history is important to identify drugs associated with hyperkalemia. A dietary history should ascertain whether LAB's consumption of potassium-rich foods, salt substitutes, or potassium supplements has increased. Dietary intake alone will not induce hyperkalemia unless renal excretion is impaired. Usually, the glomerular filtration rate must be less than 10 to 15 milliliters per minute, unless there is concurrent hypoaldosteronism or distal tubular potassium secretory defects. LAB's renal insufficiency is mild, with an estimated creatinine clearance of 40 milliliters per minute. Conditions associated with low renin and aldosterone, which usually present as hyperkalemia and hyperchloremic metabolic acidosis, decrease potassium excretion by the kidneys. These include diabetes obstructive uropathy, sickle cell disease, lupus nephritis, and various tubulo-interstitial diseases, e.g., gouty nephropathy, analgesic nephropathy. Adrenal insufficiency presents commonly with hyperkalemia because of mineralocorticoid deficiency. LAB's hyperglycemia because of poorly controlled diabetes may cause movement of potassium-rich fluid from the intracellular space to the extracellular space because of the increased tonicity. Elevating the plasma tonicity by 15 to 20 milliosmoles per kilogram will increase the plasma potassium concentration by 0.8 milliequivalents per liter. Patients with diabetes, mineralocorticoid deficiency, or end-stage renal failure, which commonly results in hyperenanemic hypoaldosteronism, are particularly susceptible. LAB is also taking several medications that may impair her ability to excrete potassium. Captopril indirectly decreases aldosterone secretion by decreasing the formation of AT2. Ibuprofen inhibits prostaglandin production as well as renin and aldosterone secretion. Other drugs that cause hyperkalemia by impairing renin and aldosterone production include AT2 receptor antagonists, beta-adrenergic blockers, lithium, heparin, and pentamidine. Triamterene, a component of her diuretic, inhibits tubular potassium secretion, as do amiloride, spironolactone, high-dose trimethoprim, cyclosporine, tacrolimus, and digitalis preparations. By inhibiting sodium-potassium ATPase, digitalis decreases tubular potassium secretion and reduces cellular potassium uptake. Arginine, succinylcholine, beta-adrenergic blockers, alpha-adrenergic agonists, and hypertonic solutions also cause hyperkalemia by impairing transcellular potassium distribution into the intracellular space. JVC, a 44-year-old woman with chronic renal failure, returns to the outpatient unit for routine hemodialysis with complaints of severe muscle weakness. Her vital signs are blood pressure of 120 systolic 80 diastolic, a pulse rate of 90 beats per minute, a respiratory rate of 20 breaths per minute, and a body temperature of 98 degrees Fahrenheit. Laboratory data are as follows. Serum potassium levels of 8.9 milliequivalents per liter. Total bicarbonate of 15 milliequivalents per liter. A BUN of 60 mg per deciliter. Creatinine of 9 mg per deciliter. Glucose levels of 100 mg per deciliter. The ECG reveals an increased PR interval and a widened QRS complex. So my question to you is, what clinical manifestations of hyperkalemia are evident in JVC? Hyperkalemia decreases the intracellular to extracellular potassium ratio. Hence, the resting membrane potential becomes less negative and moves closer to the threshold excitation potential. Muscle weakness and flaccid paralysis result when the resting membrane potential approaches the threshold potential, rendering the excitable cells unable to sustain an action potential. The cardiac toxicity of hyperkalemia is a major cause of morbidity and mortality, with ECG findings paralleling the degree of hyperkalemia. When plasma potassium is greater than 5.5 to 6.0 milliequivalents per liter, narrow, peak T waves and a shortened QT interval are seen. As the plasma potassium concentration increases further, the QRS complex widens and the P-wave amplitude decreases. As the level reaches 8 milliequivalents per liter, the P-wave disappears and the QRS complex continues to widen and merge with the T-wave to form a sine wave pattern. If these ECG changes are not recognized and no treatment is initiated, ventricular fibrillation and asystole will ensue. Hyponatremia, hypercalcemia, and hypomagnesemia all reduce the threshold potential, thereby increasing the patient's susceptibility to the cardiac effects of hyperkalemia. JVC's muscle weakness, ECG, chronic renal failure, and serum potassium concentration all are consistent with severe hyperkalemia. The next question reads, how should JVC's hyperkalemia be treated? Hyperkalemia with ECG changes requires urgent treatment. 3 therapeutic modalities are available. A. Agents that antagonize the cardiac effects of hyperkalemia. B. Agents that shift potassium from the extracellular into the intracellular space. And C. Agents that enhance potassium elimination. Considering JVC's severe ECG changes, 10% calcium gluconate IV should be administered at a dose of 10 to 20 ml over the course of 1 to 3 minutes. Calcium counteracts the depolarizing effect of hyperkalemia by increasing the threshold potential, thus making it less negative and moving it away from the resting potential. The onset of action occurs in a few minutes, but the effect is short-lived, lasting approximately 15 to 60 minutes. The dose can be repeated in 5 minutes if ECG changes do not resolve and is needed afterward for recurrence. With no response after the second dose, additional attempts, however, are not beneficial. When the hyperkalemia presents with a digitalis overdose, calcium should be used cautiously because it can worsen the cardiotoxic effects of digoxin. Because the serum potassium concentration is not affected by calcium administration, maneuvers should be used to shift potassium from plasma into the cells. 3 modalities are available: insulin and glucose, beta-2 agonists, and sodium bicarbonate. Insulin rapidly shifts potassium into the cell in a dose-dependent fashion. The maximal effect occurs at insulin concentrations greater than 20 to 40 times the basal levels. Therefore, endogenous insulin secreted in response to dextrose administration is insufficient, and exogenous insulin must be administered. Although high concentrations of dextrose may worsen hyperkalemia, particularly in diabetic patients because intracellular potassium may be shifted to the extracellular space owing to the elevated plasma tonicity, it is always administered with insulin to prevent hypoglycemia. Regular insulin, 5 to 10 units, can be given with 50 ml of 50% dextrose as IV boluses, followed by a continuous infusion of 10% dextrose at 50 ml per hour to prevent late hypoglycemia. In dialysis patients susceptible to experiencing fasting hyperkalemia, 20 units of insulin can be added to 1 liter of 10% dextrose and administered at a rate of 50 ml per hour to prevent the hyperkalemia. The insulin-dextrose combination lowers serum potassium by direct stimulation of cellular potassium uptake and potentiates the potassium-lowering effect of beta-adrenergic stimulation. The reduction in potassium is apparent 15 to 30 minutes after the start of the therapy and persists for 4 to 6 hours. In a diabetic patient who is both hyperkalemic and hyperglycemic, insulin alone may be insufficient. If the patient has end-stage renal disease, the insulin-glucose combination is more predictable in lowering plasma potassium concentrations than sodium bicarbonate. Beta-2 agonists, by binding with the beta-2 adrenoreceptor to activate adenylate cyclase, have an additive effect with the insulin-dextrose combination in decreasing serum potassium. When albuterol nebulization is used alone, the hyperkalemic effect may be inconsistent. Although side effects of albuterol nebulization are minimal, these agents can cause tachycardia and should be used cautiously in patients with underlying coronary artery disease. Although not commercially available, IV albuterol has a faster onset of action, that is 30 versus 90 minutes. In contrast, nebulization is easier to set up and is less likely to be associated with tachycardia, but multiple doses are often necessary to attain an adequate response. In conjunction with the insulin-dextrose combination, albuterol, that is 20 mg dissolved in 4 ml of saline, can be administered by nebulization and inhaled over the course of 10 minutes to further decrease serum potassium, if necessary. Although sodium bicarbonate has long been recommended for the acute treatment of hyperkalemia, its efficacy in this setting has been questioned. The usual dose, 44 to 50 milliequivalents, is infused slowly over the course of 5 minutes and repeated in 30 minutes when necessary. Alternatively, it can be added to dextrose and saline solution to form an isotonic sodium bicarbonate infusion. The hyperkalemic effect is variable and may be delayed up to 4 hours, and it is reportedly ineffective in patients on maintenance hemodialysis. Although bicarbonate therapy is not a reliable option in the acute management of hyperkalemia, it may be beneficial in patients with severe metabolic acidosis, that is a pH less than 7.2. Potential complications of sodium bicarbonate therapy are volume overload and metabolic alkalosis. The definitive treatment of hyperkalemia is removal of potassium from the body. Sodium polystyrene sulfonate, abbreviated as SPS, with sorbitol is an ion exchange resin that binds potassium in the bowel and enhances its excretion in the stools. Each gram of sodium polystyrene sulfonate exchanges 0.5 to 1.0 millimole of potassium for an equal amount of sodium. Sodium polystyrene sulfonate can be administered orally or rectally. The latter route is preferred in the symptomatic hyperkalemic patient because intestinal potassium exchange occurs mainly in the ileum and colon. A dose of 50 grams of sodium polystyrene sulfonate in sorbitol can be given as an enema, retained for at least 30 to 60 minutes, at 4-hour to 6-hour intervals. For non-emergent removal of body potassium, 15 to 60 grams of sodium polystyrene sulfonate with sorbitol suspension can be given orally, which can be repeated as needed. The onset of action is approximately 1 to 2 hours after administration. The major side effects are GI intolerance, including constipation, diarrhea, and sodium overload. Potentially fatal intestinal necrosis, though rare, have been reported with the use of sodium polystyrene sulfonate with sorbitol. It is unclear if intestinal injury is caused by sodium polystyrene sulfonate or sorbitol, but FDA has released a safety warning against the use of sodium polystyrene sulfonate in individuals with impaired bowel function. Hemodialysis is the most efficient way to remove potassium. Potassium clearance by peritoneal dialysis is lower than for hemodialysis. The hyperkalemic effect is immediate and lasts for the duration of dialysis. However, the amount of potassium removed is variable. Dialysis with a glucose-free dialysate will remove 30% more potassium than one containing 200 mg per deciliter of glucose. Although JVC is receiving chronic maintenance hemodialysis, the severe cardiac effects of hyperkalemia she experienced warrant immediate institution of the aforementioned measures while awaiting preparation for dialysis. Loop diuretics, which enhance kaliuresis, are rarely useful in managing severe hyperkalemia, especially in patients with renal dysfunction. Two new oral agents, patiromer and sodium zirconium cyclosilicate, currently still under investigation, have been shown to be effective in reducing serum potassium concentrations in patients with mild to moderate hyperkalemia. As the studies conducted thus far are short-term studies and excluded patients with severe hyperkalemia, the long-term beneficial and adverse effects of these agents need to be further evaluated. After JVC's condition stabilized, she admitted to eating a lot of fruits in the past few days. Because non-compliance with dietary potassium restriction is the most common cause for acute and chronic hyperkalemia in a dialysis patient, JVC should be counseled to consume potassium-rich foods in moderation. Medications that impair JVC's extrarenal potassium handling should be avoided. If JVC remains chronically hyperkalemic, sodium polystyrene sulfonate will then be needed, probably 3 or 4 times weekly. If hyperkalemia is associated with metabolic acidosis, however, an alkalinizing agent should be added to maintain a serum bicarbonate concentration of about 24 milliequivalents per liter. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arora, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 373.